Good morning again. So my charge today is to talk about both the theory and the practice of naming genetic disorders and the progress that's been made in revealing the truly remarkable genetic heterogeneity underlying Loeys-Dietz syndrome. One could ask, well, what should be the underlying principles? And I think the one that we find to be most compelling is the desire to take information about a given person and to make informed predictions about what they might encounter in the future and what their family member might encounter in the future. By not focusing on the average patient with a vascular connective tissue disorder, but doing our best to focus on the person in front of us, what gene is involved, what is their particular mutation, that we would be able to do better at providing informed counseling and management. So, these kinds of principles have been in place for some connective tissue disorders for a while. And, one thing we could ask is, how are they working? For Marfan syndrome, for example, here's a very severely affected young man. He has all of the classic manifestations of Marfan syndrome that showed up at birth and were rapidly progressive. He has a defined fibrillin-1 mutation and again clearly satisfies diagnostic criteria for Marfan syndrome. Now, if we compare that to this woman who's 67 years old, she has no facial, ocular, or skeletal features, did experience a type B dissection at 55 years and aortic root replacement ultimately at 65 years. But no one would argue that she's very different from that other child. Yet she has a mutation in the fibrillin-1 gene and has a diagnosis of Marfan syndrome. So if we go to the guidelines for Marfan syndrome, they state that the presence of aortic root enlargement or dissection and the identification of a bona fide FBN1 mutation is sufficient to establish the diagnosis. And they stressed in these guidelines that the paramount need is to maintain good health through proper counseling and the application of sound anticipatory management practices. So, how has this worked in Marfan syndrome? Well, I think that anyone could argue that it's worked exceedingly well. The number of people experiencing aortic dissection has fallen dramatically because the use of these diagnostic and management guidelines has led to the widespread practice of performing aortic root surgery at around 5 centimeters. That's what makes sense for people with Marfan syndrome. In contrast, mutations in the COL3A1 mutation that cause vascular Ehlers-Danlos syndrome mandate a very different management practice, including diagnosis-specific interventions like considering the use of vitamin C and certainly much more wide imaging than would be appropriate in Marfan syndrome. So, we all have recently heard about Loeys-Dietz syndrome, that it has many features that overlap with Marfan syndrome, also many unique features, prominently including craniofacial and vascular differences from Marfan syndrome. We recently talked about the fact that this condition initially was shown to be caused by mutations in either the type 1 or type 2 TGF-beta receptor subunits, and that it associates with high TGF-beta signaling in the vessel wall. If you go to the Loeys-Dietz conference that we recently had in the States, or you come to this conference, I'm sure that people appreciate that there are similarities that you can see in facial presentation of Loeys-Dietz syndrome. I remember a gentleman at the recent American conference stating that was the first time that he felt that he was at a patient advocacy meeting where he belonged. He saw himself in other people in the crowd. Sharing his stories rang true with the stories that he was hearing from other people. So significant progress has been made. As I mentioned, we're now seeing over 300 families. We have information on over 600 families worldwide. There's a multinational collaborative network that has been working toward better defining natural history. There are foundations in both the US and Canada. What is the impact of education? How is this playing out in the general community? I would say that perhaps 4 or 5 times a week, I get an email from someone saying, I saw enter LDS feature here, and on the basis of this performed such and such a diagnostic test that is specific for Loeys-Dietz syndrome, and thank God I found, enter serious and actionable Loeys-Dietz syndrome features. So I think that education has gotten the word out to diverse groups of physicians that now sit up and recognize that when they hear the name Loeys-Dietz syndrome, that it's not business as usual. Now the number of genes associated with Loeys-Dietz syndrome has expanded, initially due to the excellent work from a group in Netherlands. Here's a gentleman that we care for with a mutation in the SMAD3 gene. He has hypertelorism, bifid uvula, blue sclerae, translucent skin, but really importantly, he has things that would not have been thought of to look for if not for this specific diagnosis, like very significant cervical spine instability and aneurysms, not only at the aortic root, but also primary dissections of his carotids, his iliacs, and existing aneurysms in his vertebrals and his celiac axis. So I think he's getting better care because people were keyed into the possibility of some of these findings because of the diagnosis. Likewise, this is a young man with a TGF-beta 2 mutation, another gene that has been associated with features of Loeys-Dietz syndrome. Again, cleft palate, exotropia surgery as a child, club foot deformity requiring surgery. I mean, there's really, it's really unavoidable to say that the diagnostic term that best describes him would be Loeys-Dietz syndrome. And we think that, again, it's going to allow for us to better anticipate what he might experience in the future. There is great biological plausibility for this. All genes that are causing this phenotype that appears to be unified relate to genes that are primarily within the TGF-beta signaling pathway. Again, the ligands shown at the top, the TGF-beta molecules themselves, the receptor subunits, and intracellular intermediates, including SMAD3. And this is very similar to lots of other conditions. For example, in a condition that's called Noonan syndrome, there are many genes that are known to cause the phenotype, and they, again, all are in the same pathway. So it just makes biological sense. No, there are other opinions, and there are good observations that mutations in these genes can cause very subtle, very mild phenotypes, including familial thoracic aortic aneurysm and phenotypes that are very reminiscent of Marfan syndrome. And we think that it might make sense to parse people based upon how they look, but it would only make sense if the mutation within a given family was always causing the same condition within that family. It would allow us to say, oh, you have that mutation, I can predict that you're going to only have vascular disease, for example. Now, here's one case study. It's a mutation in the TGF-BR2 gene. Here are 3 families that are segregating this mutation that had been reported as a mutation that causes isolated familial thoracic aortic aneurysm. So in the first family, the woman shown all the way up on the left really had very, very subtle findings of Loeys-Dietz syndrome, mild translucent skin, a little bit of joint laxity, a normal aortic root when last evaluated, and again, perhaps minimal tortuosity of her carotids and vertebrals. But if you look at her 13-year-old sister, suddenly we're kicking in with very broadly spaced eyes, a broad uvula, blue sclerae, very translucent skin, and she has widespread arterial tortuosity and both an aortic root and ascending aortic aneurysm younger than her sister. If you look at their aunt, she has hypertelorism, bifid uvula, blue sclerae, virtually every skin and skeletal finding, widespread tortuosity, vertebral artery dissection at a very young age, and a cerebral aneurysm that required surgery. Now, if you look at this woman's mother, she had a catastrophic clinical course with, very severe tortuosity and craniofacial findings, but 6 vascular surgeries, throughout the entire arterial tree, all as primary surgeries, and ended up dying of sudden death due to a cerebral bleed. Finally, the last family has extreme craniofacial, skeletal, vascular, club foot deformity, virtually the classic Loeys-Dietz syndrome phenotype. So I think it's a really interesting question. Why is the same mutation playing out differently in different people in the same family and also between families? And my bet is that the answer is going to be modifiers, that based upon the other genes that we inherit from our parents, some of them are going to suppress the tendency of the mutation to cause severe findings. Others are going to allow the mutation to declare its full potential. I think that as I talked about in a talk earlier this morning, identifying those protective modifiers will likely teach us about new medications that could perhaps be used to care for people with Loeys-Dietz syndrome. If you look at other mutations, for example, described as causing Marfan syndrome, same mutation in this young lady, again, virtually every Loeys-Dietz manifestation. A different mutation described as causing Marfan syndrome, again, this young man is classic for Loeys-Dietz syndrome. So the answer is that yes, there are mutations that in isolated cases can cause very subtle phenotypes, that virtually every one of those mutations is seen in patients that have, the typical presentation of Loeys-Dietz syndrome. And what I think might best illustrate that is this table that's showing the features in different disorders, one called Marfan syndrome, a related condition called Sprintzen-Goldberg syndrome, and then the 4 different genes that have been identified as being associated with Loeys-Dietz syndrome phenotypes. And I think that this nicely shows that there's lots of overlap with Marfan syndrome in these features up on the top, but then there's all of these other features shown in green at the bottom that are unique to the class of conditions that are referred to as Loeys-Dietz syndrome. So, I think that we should use this information wisely, but I also think that we should all work together to collaboratively explore the range of conditions and the predictors of outcomes and the responses to treatment within these different classes. So, what the guideline paper suggested is that the term Loeys-Dietz syndrome is informative for these genes. They do predict what can happen later in your life or in the lives of your family members, but use locus-specific designations. For one gene, we'll use the designator 1, for the second gene 2, 3, 4, et cetera. And in that way, as we learn that there are differences between the conditions caused by one gene or another, we can fold them into the specific descriptors for that specific form. So what have we learned now that should be common to all people who have been diagnosed within the Loeys-Dietz syndrome spectrum? I think most imperative to image widely, not just the aortic root, but actually the head through the pelvis. That medications based upon studies in animal models do show promise to be effective.
Dr. Edward Hickey, start call to critical care unit. Dr. Edward Hickey, start call to critical care unit. Dr. Edward Hickey, start call to...
We get it. We understand. That the cervical spine needs to be imaged, that there needs to be specific counseling about the risk of inflammatory bowel disease and severe severe allergic reactions, and that there should be careful consideration of tailored surgical guidelines. Again, not just based upon the diagnosis, but based upon the family history of that patient, based upon what's known about the mutations in that particular gene, or patients with the identical mutation. I am absolutely sure that refinement will occur with further research and knowledge. There is now a condition associated with mutations in the TGF-beta3 gene. It's very early on. I know of information for about 5 patients. But what you can already see is that findings that are being reported so far are again very reminiscent of the classic Loeys-Dietz syndrome phenotype. But we'll wait and see exactly how that plays out. So I think with everyone focusing on what's best for families and patients, and collaborative efforts to really do our best to come up with the best clinical designations, that the future looks bright. So thank you for your attention. I'd be happy to answer questions.
Dr. Glenn Van Arsdale,